Hey everybody, my name is Windsor Kiang, and today I'll be giving you a little sneak peek into what I'll be presenting live at the International Youth Research Conference this coming July. I'll be telling you about a little project that I've been working on with a few of my colleagues. So before I begin, let me give a quick shout out to Kevin Sia, Otis Bailey, Aravka Parlas, and Derek Wang for their amazing and undeniable contributions to this project. Our project, Safer DC, which is an acronym for the Safer Allocation of Fentanyl Emergency Response in Washington, D.C., aims to solve a real-world issue in the United States Capitol, a city that my team worries so much about because we are actually stationed right here in the district. Our research focuses on one central question: how can mathematical modeling help Washington, D.C. reduce fentanyl overdose deaths in a targeted, cost-effective, and data-driven way? Now, the goal of this presentation is to walk you through step-by-step our evidence by first defining the scale of the problem, second, identifying the most important risk factors, and finally, proposing a targeted intervention that can reduce deaths across the entire district. But first, what is the actual problem? Well, Washington, D.C. is ground zero. It has the highest overdose death rate in the entirety of the country, with 94% above the national average and 96% of fatal opioid overdoses involve fentanyl. Over the past 5 years alone, D.C. has averaged roughly 400 opioid deaths per year. In 2023 alone, 518 people died of opioid overdoses. Just to put that into perspective, D.C. had 274 homicides that very same year, which means that opioid overdoses claimed twice as many victims. That is a 300% increase since 2013, but the crisis isn't even evenly distributed because Black residents, who make up only 84% of overdose deaths, despite only being about 45% of the population of Washington, D.C. Wards 7 and 8 of the district consistently show the highest of these rates. This is both a public health crisis and an equity crisis. Too many people are dying, and the burden falls onto specific communities. Any effective solution must start here. But what is our methodology? Well, to study all of this issue, we implemented a 3-phase actuarial framework using 9 mathematical models. Phase 1 was defining the problem, which we use a time series model, an ARIMA model, and an SIR model to quantify the trajectory and estimate future deaths. Our Phase 2 was feature importance, which used random forest and XGBoost to isolate which demographic and socioeconomic factors drove overdose mortality. And Phase 3, which mitigation design, used logistical modeling, kernel density estimation, emerging hotspot analysis, treatment desert analysis, and k-means clustering to translate findings into targeted, bias-free resource allocation, which we will actually use to mitigate deaths in the district, because we didn't want to just describe the crisis. We wanted to move from prediction to risk identification into actual intervention, and that's exactly what our project does. So let's get straight into it. Phase 1, we have to define the actual problem. In Phase 1, we estimated the future trajectory of fentanyl deaths in DC. The ARIMA model showed nationwide fentanyl deaths beginning to plateau, with DC mirroring the national trend, both show an R-squared of 0.72. DC's trajectory is tightly linked to the national fentanyl supply chain. Our modified SIR model, which is traditionally used for infectious diseases, was adapted for opioid misuse, including the possibility of relapse. It projected the affected population flattening at around 4,600 residents from 2026 to 2031, applying a 3.62% death rate and a 96% fentanyl prevalence gives us our central estimate: 807 projected fentanyl-related deaths in Washington, D.C. in the next 5 years if nothing changes. But that's something needs to change right now. That number is going to be the baseline, which is what our recommendation is going to be compared against for every single mitigation strategy that we're going to calculate in the following phases. So what's Phase 2? Feature importance. So next, who is actually at the most risk? Well, a random forest produced a test R-squared value of 0.967. XGBoost hit 9.981. 2 different model architectures converging on the exact same risk factors. That's how we know that these findings are real and not coincidental. DC outpaces the national median on almost every single major risk factor. Illicit fentanyl death rate is far above the median. Overall male overdose rate is far above the median, and the share of households in the 10,000 to 15,000 income bracket is also well above the median. Low income was one of the strongest socioeconomic predictors we found. The only area where DC was at all similar to the national median was the male age 35 to 44 group. who was overdosing. So this crisis is not just random, it is patterned, measurable, and tied to specific vulnerabilities that we're aiming to target. But where exactly are these crises actually concentrated? So after identifying who, we need to ask where. KDE identified high density overdose areas in wards 1 and 2, with significant clusters in wards 7 and 8, which is Columbia Heights, Logan Circle, and Chinatown, among the top concentration areas. Our emerging hotspot analysis found persistent hotspots in wards 1, 6, and 8, and developing hotspots in wards 5 and 8 as well. Southeast DC is not only historically affected. In some areas, the problem is still actually getting worse. So the treatment desert analysis showed that Southeast DC faces both the highest overdose burden and the worst access to hospitals and treatment facilities. The areas most effective are also the areas that are least served. This makes sense. Wards 7 and 8 emerge as critical priority zones across every single model. So those are the areas that we're going to target in our infrastructure. So what is our first actual recommendation? It's targeted naloxone distribution. So our first recommendation is targeted naloxone distribution, the most direct way to stop an overdose from becoming a death. Using K-means clustering, we propose distributing 20,000 naloxone kits across 48 DC neighborhoods, risk by tier, prioritizing areas with the highest overdose risk. Our logistic model, shown right here, shows 80% of the overdoses currently receive naloxone. Untreated, let me show that table. Untreated overdoses face a 10% death rate versus just a 2% for treated, meaning that each 1% coverage gain 1% coverage gain saves roughly 5 lives per year. Now, this strategy projects 368 lives saved in the next 5 years, a 45% reduction from the 807 death baseline that we established earlier. But what is the cost? $1.07 million per year. But what's the benefit? $803 million every single year, using the federal value of a statistical life. That is a 750 to 1 return. The critical zones, Twining, Naylor and Hillcrest, Fort Dupont, Southwest Waterfront, and Chinatown are all targeted and will be utilized effectively. But it's not just this, because we have our second recommendation as well. Our second recommendation is fentanyl test strip distribution, acting before the overdose actually happens. Our XGBoost model identified illicit fentanyl rate as the single strongest predictor of overdose mortality. Fentanyl test strips directly counter that by letting users detect fentanyl before consumption. We propose distributing 100,000 strips through pharmacies, health centers, and transit hubs in the K-means clustered critical zones, modeled after Ohio's Project Dawn and California's harm reduction programs. NIH benchmarks estimates that this association, NIH benchmark estimates associate this with a 7% mortality reduction, about 9.45 lives saved per every single year. The cost is $130,000 annually, but the benefit is $128.3 million. Benefit to cost ratio is 952 to 1. This is the hardest ROI that we'll see across all 4 of our strategies, and this is the best one that we can implement. Low cost, scalable, and it works upstream before someone else ends up in another crisis. But our third recommendation is expanding medication-assisted treatment, otherwise known as MAT, which addresses opioid use disorder itself. Naloxone test strips save lives, but they don't permanently shrink the affected population. Only MAT shifts the long-term plateau downwards. Buprenorphine is associated with a 76% reduction in fatal overdoses, yet only 4.1% of Medicaid beneficiaries received opioid medication after an overdose, and only about 25% of people who need MAT in the US actually receive it. This is an issue that we can solve under today's legislation. We propose expanding coverage for 1,000 additional patients in wards 7 and 8 in Washington, D.C., partnering with MedStar, Howard University, and United Medical Center. The cost might be $7.77 million per year, but the annual economic benefit is $441 million. The net benefit, the net ROI is 57 to 1. This might be a lower ROI than the other two, but it might actually be the single most important long-term intervention because it treats it like a disease, not just an emergency, stopping it before it spreads. Our fourth and final recommendation is addressing the roots. Poverty, housing instability, and lack of economic opportunity fuel addiction in the first place. Our random forest model showed economic features as strong predictors of overdose death rates. Households with incomes between $10,000 and $15,000 had the highest importance score among economic factors at 0.01. At point 1, for wards 7 and 8, we recommend 4 targeted intervention, expanded job training for residents in the highest risk income brackets, stronger affordable housing initiatives, because housing instability directly raises addiction vulnerability, direct financial assistance for households that again fall into that $10,000 to $15,000 brackets, and expanded community health outreach, using local workers to connect residents with MAT, naloxone, and test strip programs. Now, this might be hard to quantify its impact, but a complete solution has to address not only the overdose response, but the conditions that make people vulnerable in the first place. So let's put it all together. Our analysis shows a clear path from 807 projected deaths to roughly only 350. Naloxone distribution costs $1.07 million per year, a 750 to 1 return. Test strips is at 952 to 1 return. MAT expansion has a 57 to 1 return combined. This $8.97 million annual investment generates approximately $1.37 billion in economic benefit and overall 153 to 1 return. All 3 interventions together projected more than a 55% reduction from the 807 death baseline. But the most important number is not the ROI, it is the lives. Naloxone alone projects 368 lives saved by 2031. Combined with the test strips and MAT, the total impact might be so much larger, and every dollar spent on this is a dollar that fights the most preventable death crisis in our nation's capital, in our nation in general. Our research shows that DC's fentanyl crisis is severe, measurable, and geographically concentrated. 807 deaths between 2026 and 2031, but that outcome is not inevitable. Targeted naloxone distribution, fentanyl test strips, expanded MAT access, and socioeconomic intervention can cut overdose deaths by more than a half. Every model points to the same place first, wards 7 and 8 of Washington, D.C., because they carry the biggest burden and the widest care gap, something that Safer DC can finally solve. So here's the purpose of Safer DC: to use mathematical modeling, not just to understand a crisis, but to guide its action and to make actual impact. Lives are priceless, so let's treat them as such. Thank you so much.